and I'm one of the co-conveners of DRNS together with Anna Ross, and the rest of the DRNS team is here as well, coordinator Marissa Bruce and admin Megan Kalman. So just some brief housekeeping before we start. Please mute yourself if you haven't already, just to make sure that there's no background noises, no vacuum cleaners or lawn mowers in the background as Michael is speaking. We are recording this, as Megan already put in the chat, so take your camera off if you don't want to be in the recording as such. And we will have a decent amount of time at the end for Q&A, so there will be a space for you to unmute yourself and ask questions for Michael. But if you don't want to ask a question yourself, you can put questions in the chat, and I will do my very best to keep up with the chat and ask questions as we get to the Q&A. And just a reminder, as we usually do for our events, just to remind everyone that we're coming from very different perspectives. We might not necessarily share exactly the same opinions or views on things. So a reminder for everyone to engage in respectful dialogue as you engage in the Q&A or in the chat. So that's just a reminder. It's never a problem, but it's always good to remind people just to kind of see the different perspectives people are coming from. But without further ado, we are joined by Professor Michael Eddleston today, who is going to speak to us about an ongoing clinical trial testing flumazenil, intramuscular flumazenil for benzodiazepine overdoses. So Michael will speak for half an hour or something around that time, and then we'll open up for Q&A. So Michael, I will just pass it on to you to share your slides and give us your presentation.
Hi, Lisa. Hi, everybody. Thank you very much for inviting me to give this talk. I hope you all find it interesting, and I hope you don't find I'm teaching you to suck eggs at times. Why is it not? Try and get it to go up. The problem is this little camera in the corner, which... Fine. Does that look right?
Yeah, it's in presentation mode now. Perfect. Thank you.
Well, thank you very much. I hope you all find this interesting, and I look forward to your questions at the end. As I say, I'm a clinical toxicologist. I work at the University of Edinburgh and in the Royal Infirmary in Edinburgh, where I see patients who take overdoses. So my focus is very much on treatment rather than so many of the other aspects, or many of you are working on around this issue. So I have no conflicts of interest. As we all know, Scotland is the ground zero for European drug death crisis over the last 15 years or so. A slide many of you will know, drug-related death in Scotland, 1,017 in 2024. In 2022, our incidence was 248 per million. It was 328 at its peak with a 1,339, which is just so much higher than the rest of Britain and the rest of Europe. So it's really very distressing. So it's similar to the USA, but there's different causes probably going on. We have three waves of the opioid overdose crisis in the United States. Early on, from around 2000 onwards, there was a rise in prescription overdose deaths from oxycodone in particular, the hydromorphone and other tablets. And then when that was kind of clamped down upon, the overprescribing in 2010, there was a rise of heroin deaths. You can see here the blue deaths rising over time. And then suddenly about 2013, there was this huge rise in deaths with fentanyls in particular. And that's the kind of predominant cause of the majority of deaths in the States at the moment from opioids. If we look on the right-hand side, you can see the opioids here at around 70,000 deaths. Psychostimulants, particularly methamphetamine, has been a key cause of death in the United States, and then cocaine. Clearly, cocaine is rising in Scotland, but the numbers are still much less than this. You can see that heroin has come down over the last 2 or 3 years as fentanyls have taken off. So are Scottish rates so terribly high due to fentanyl? The answer seems to be no. Similar to, I could find data here from England and Wales, there were 60 deaths registered from fentanyl in 2024, which gives an incidence of 0.1 per 100,000 compared to 22 per 100,000 in the USA. And even though there's the potential for fentanyl and these extremely potent carfentanil or similar fentanyl analogues, it doesn't seem to be a problem, from my understanding, in Scotland at the moment. What does seem to have happened since 2015 is a combination of really potent benzodiazepines and normal potency opioids, heroin and methadone. So if we see the data here, around 2015, there was a sudden increase in total drug deaths and drug deaths including heroin and other opiates. At the same time, there was a marked increase in the combination of benzodiazepines, particularly street diazepines, with the opioids. So at this point, there was about 75% of opioid deaths had a benzodiazepine on board. It's probably around 65% at the moment. And that does seem to have correlated with this really marked increase in deaths from around 2014 onwards. As many of you know, initially it was alprazolam, then switched over time to atizolam, then more recently bromozolam, but things keep changing. This study came out of Iona a few years ago. Across the UK, bromozolam was what patients were coming into hospital with, not so much dying. This data is patients who lived in ED presentations. There's also the problem here of changing epidemiology. In 2014 in Edinburgh, there was a particularly terrible epidemic, ethyl phenidate overdoses, extremely agitated patients coming in, many of them with the skin and cardiac problems that seem to come with ethyl phenidate use. But the trading standards closed down or forced several shops in Edinburgh to stop selling this product. And what we saw over the next few years was ethyl phenidate completely faded away. And what we had was the novel benzodiazepines was what became the most common novel psychoactive substances being used in Edinburgh. So there are very rapid changes. And there's also changing of variable benzodiazepine epidemiology. This is data from Julie McAdam in Glasgow. And here you can see the atizolam was very large in 2023, but then by 2024 it's becoming less important. Bromozolam was probably staying about the same, and then new ones are coming on, gidazepam and clonazepam. The study I'm going to tell you about, RUFUS, in Edinburgh, practically all the patients we see in the study so far have taken diazepam, both prescribed and street diazepam, while in Kirkcaldy, patients have predominantly taken illicit benzos, and particularly clonazepam. So looking across different parts of Scotland at different times, there's different benzodiazepines and different drugs being used, adding to the complexity of the picture. There's also gabapentinoids. Gabapentin and pregabalin used as analgesics and anti-epileptics, but have become a common use in drug use. So if you can look at the data on drug deaths in the UK, and from 2010 onwards, there was a marked rise in the number of deaths, which is here on the left-hand side, of patients with particularly pregabalin, around 500 deaths a year from pregabalin, and probably 100 deaths in gabapentin. And that correlates very closely with the prescriptions of these two drugs. Of note that the vast majority of deaths were not occurring in patients with either pregabalin or gabapentin alone, but the majority had opioids on board. So again, it's a combination product. And this is important for the study to bear in mind that gabapentinoids have become more and more important in the UK and in Scotland. So what antidotes do we have for unintentional overdose? So naloxone, it seems to be highly effective. It's available either as a syringe here with 5 doses of 400 micrograms and 2 needles, or as the naloxone 1.26 or 1.8 milligram intranasal naloxone. The potency or the bioavailability, how much gets into your body, seems to be about 50% from the nasal one compared to the injection into the muscle. That's why there's larger doses. But the 1.8 is something like 800 micrograms of naloxone, or 2 doses from this prinoxide injection. Now, why do we know that works? And the best data in the world probably comes from the study from Scotland. This was a paper that came out by Sheila Burden and Macaulay and colleagues, looking at excuse me, the naloxone program, where individuals discharged from prison were given naloxone, and they compared before the program and after the program. So in 2006 to 10, 9.8% of opioid-related deaths of 193 were in people who had just been released from prison. And it's well known that release from prison is a high-risk period of time when people restart using street opioids. However, that went down to 6.3% of ORDs in 2011, 2013. It's down from 193 over that 5 years to 76 over 3 years. And there was a difference of 3.5%. They calculated there were 42 fewer prison release deaths during 2011-13, when 12,000 naloxone kits were issued at a current prescription cost of £225,000. So the number needed to treat from that program was £5,000 per life saved. If you imagine that person was going to live for 10 or 20 years on, then the life per life year saved was 250 or 500 pounds, which is incredibly cost effective in terms of public health interventions. So this is pretty good evidence that naloxone works in the community. But what we're not using at the moment is flumazenil. Well, flumazenil is licensed for intravenous use in hospitals. So when someone gives a diazepam, a benzodiazepine during a procedure, and the patient's too sedated afterwards, the anesthetist can give flumazenil to reverse that. But that's pretty much the only thing it's licensed for. It's licensed for intravenous use in that situation. Now, why don't we use flumazenil? And that's because of a fear of complications. When it first came out in the 1970s, there were quite a lot of case series and papers of patients having seizures after getting flumazenil. There's also data on cardiac dysrhythmias that occur. And the ToxBase, which is the database run from Edinburgh, which advises doctors across the UK on how to treat patients with overdoses, has recommended not using flumazenil. The reason for that is because many patients in the past had taken amitriptyline at the same time. So the reason for the seizures was a co-ingestion of amitriptyline and benzodiazepine. When benzodiazepine was taken out of the picture by the use of flumazenil, amitriptyline was on board, and that is common cause of seizures and cardiac dysrhythmias. So it seems to be it's the combination of those two tablets of those two drugs in a patient that increases the risk of seizures after flumazenil. It looks like the incidence is quite low. When we discuss this with colleagues like Jason Wallace at the Scottish Drugs Forum, his view is, well, if on one side people are dying from benzodiazepine and opioids, and the risk of using it is seizures themselves don't kill people, we should be trying to use it. And why are we not using it? And that was the beginning of the study that came out. So the issues we have at the moment, we're going to have to give flumazenil either intramuscularly or intranasally to work in the community where lives might be saved. Currently, it's only licensed for use in hospital for the intravenous route, which is very difficult sometimes in these patients. And also, when patients get to hospital, flumazenil is rarely life-saving at that point because a good hospital can keep people alive with a benzodiazepine overdose quite easily, even in combination with opioids. That's not the situation in the community. The first thing is we don't know whether intramuscular flumazenil works. Now, you'd think it should work. Most drugs given intravenously will work intramuscularly. But there's very little experience. There was some coming out of France, and both of those were negative and suggested it didn't work. There was a randomized controlled trial of giving flumazenil on a reasonable dose. And 15 minutes, patients were not more awake if they got flumazenil intramuscularly where they were if they got it intravenously. And then there was some anesthetic data which wasn't very clear. However, there's one reassuring study of a veterinary study, which looked at the reversal of midazolam-induced respiratory depression in dogs. And if the dog was given saline placebo, it took about 28 minutes for the respiratory depression to settle. This is not about waking up, it's about making breathing working properly. If you give intravenous flumazenil, it took about 2.5 minutes, while intramuscular took about 5 minutes. So it looked very clearly like intramuscular flumazenil did work as we'd expect. It just took a little bit longer, which in terms of waking them up slowly is probably better than waking up suddenly. So having a slightly slower effect intramuscularly is probably not a harmful problem. The other questions I've alluded to already is we don't know how many patients are going to have tonic-clonic seizures or even status epilepticus. And status epilepticus is the problem because of that is the point where you have to decide how you're going to treat these patients if you would normally treat with benzodiazepines and you're giving them flumazenil, so you can't really use benzodiazepines.
Move towards diversity, equality and inclusion in nursing study.
And then, so the literature suggests seizures occur in less than 1% of cases, even in high-risk patients who are benzodiazepine dependent. So again, it comes down, if the risk of death is high from these benzo and opioid combinations, perhaps that risk of seizures is perfectly acceptable. There's no status epilepticus being reported in the literature, so it doesn't look like people getting really severe seizures, even if they do get one after flumazenil. So the issue is if flumazenil can work safely and effectively intramuscularly, then we might save lives pre-hospital by giving flumazenil. So this is the randomized control trial, the slide which sums it up. So the population of the study is patients with reduced GCS, and I'll come to what this RAS score means later on. Due to suspected benzodiazepine overdose, it's really not possible at the moment to rapidly confirm whether someone's taken a benzodiazepine, especially with the novel benzodiazepines coming on board. So this is simply someone who is believed to have taken an unintentional overdose, probably including benzodiazepine. In Scotland, that includes pretty much everyone. who's had adequate doses of naloxone to get rid of any opioid toxicity that's there. Now, that adequate dose may be 0 because there's no indication at all of any opioids on board, or 1 or 2 milligrams of naloxone to completely reverse any effects of the opioids. So you're really left with what probably is benzodiazepine overdose. There's no consent taken, and I'll go through that. It's a deferred consent study. The second analysis involves benzodiazepines. We're looking for benzodiazepine in the blood. Now, if the patient's got no benzodiazepines on board, flumazenil won't be expected to work, so we can exclude them from a secondary analysis. The intervention is intramuscular flumazenil in different doses. We give an equal volume of sodium chloride for infusion as the placebo, and we're looking for two things. What's the incidence of seizures, but also efficacy. There's no point testing a drug that doesn't work. So first of all, we have to work out what dose works and will wake people up, and then we'll try and work out whether it causes seizures. And the RUFUS study is funded by the Medical Research Council. So it has 3 stages. The first one was to try to find quickly in a typical dose escalation study, a dose that's probably going to be effective. It's far too small to test safety, and it can only give you a rough idea of the efficacy of whether it's going to work or not. But from that, we'd hope to find 2 doses. So get 2 doses which look like they're working and don't obviously cause seizures, and take them to a bigger scale study where we're going to look at 2 different doses and compare that with placebo. And then that's 189 patients. And the idea is to get 1 dose, which we can then take to a bigger study. 1 dose we might then use in the future in the community, which looks like it works. And then we're going to get a precise estimate from that dose of what the incidence of tonic-clonic seizures are after IM flumazenil. And that will be with a single dose versus placebo, looking at 374 patients in that group and comparing them with the patients in this stage 2 who also got those 2 same doses, the placebo and the dose we take into stage 3. So our inclusion criteria, again, is about acute suspected unintentional benzodiazepine overdose. That's a clinical decision by a nurse or a doctor on admission to hospital to say this is probably a benzodiazepine overdose, which isn't fully responding to a good dose of naloxone. We are accepting mixed overdoses because the vast majority of patients have taken several drugs, and you can see that in overdose. We're trying to make sure that other common causes of unconsciousness, such as low glucose, have been excluded, or head injury is another common one we look for. Now, how many patients coming into hospital have taken benzodiazepines? And Scotland's quite different to England in this. Going back to the Iona study and looking at 4 sites, 3 in England, Reading, Royal London, and St George's, and comparing that to Edinburgh, we saw that 90% of patients coming in with a suspected unintentional drug overdose had benzodiazepines on board. And the majority at that time were novel benzodiazepines. So you see that 80% of patients roughly had a novel benzodiazepine, and another 10% had diazepam. Of interest, that seems to have changed now, and the majority of people in Edinburgh take benzodiazepines, take diazepam. But you can see that a large proportion of patients have a benzodiazepine on board. In England, it's lower percentages, and more of them take diazepam. If we look at a patient who's taken an opioid, we found in Edinburgh that 100% of them had got benzodiazepines on board. So pretty much everybody we were seeing in the Iona study were taking opioids and benzodiazepines if they were taking an opioid. Again, in England, it's a lower percentage. What we weren't doing at the time was working how much taking gabapentin. So some of the patients who were unconscious in the study, who are not responding fully to naloxone, have actually taken a gabapentin overdose or pregabalin overdose. We need to exclude those from the analysis because they won't be expected to respond to flumazenil. We're looking for unconsciousness, and we're scoring unconsciousness with the RAS score, which I'll show you in a moment. And we're looking for adults who appear to be more than 16 years old. In stages 2 and 3, we can recruit anonymous patients and who we won't have their date of birth, but they look greater, more than 15 years old. So 16 or older, they can come in the study. This is the Richmond Agitation Sedation Scale, the RAS score. It's used predominantly in intensive care, but I find it very useful for patients who have taken overdoses. In the blue, you can find people who you call unconscious, so deeply sedated, unrousable, on the street, not responding to you. Those people in blue are at risk of not controlling their airway and therefore aspirating, getting complications of this sedation from the benzodiazepine and the opioid, which could cause respiratory arrest and death. Green is patients who are drowsy or normal, but they're not really at risk of harm from this level of sedation. Red as patients who are agitated. +4 is the person being held down by 3 police officers who's completely unable to understand what's going on and is very agitated and combative. Someone who's +1 is just a little bit more anxious and apprehensive and agitated than normal, but there's no real vigor or no aggression going on. So you can score patients quite nicely with the score. And what we're trying to do in this study is bring people out of the dangerous blue into the safe green without going into the agitated red. And so far, in the stage 1, we've only had one patient who went to +3 that I'm aware of. And he was simply accompanied by a nurse for the next half hour who just spoke to him and kept talking and kept kind of reassuring him, telling him what was going on. And he settled down very quickly. This seems, the withdrawal you get with the flumazenil seems much more gentle than the opioid agitation you get from naloxone use. So that's a nice thing we found so far. Exclusion criteria. We exclude patients who have epilepsy or chronic brain injury because they're going to be higher risk of having seizures. Patients who've had a seizure already before they get to hospital, they're also excluded. We don't include people who are obviously pregnant. We can't do a urine HCG test as we normally would do because of an unconscious patient. We're looking at patients with a normal ECG. Someone who's got an abnormal ECG is likely to be more a higher risk of seizures. We don't include people who are detained under the Mental Health Act. Currently, we don't recruit prisoners. However, we are after discussions with the Scottish Drugs Forum, who then went into prisons and talked to people there who were using benzodiazepines. And the prisoners there felt that they would be keen to be part of the study. So we now have approval in England to recruit prisoners, but not yet in Scotland. That process is still going on. So our primary outcomes is, have patients had a seizure within the first hour after getting flumazenil? And the second one is the efficacy. Can we move people from the blue area into the green? So we're looking for the -2 into 0, alert and calm at 15 minutes. We're not looking for them to go into the +1s, 2s, or 3s. We're looking for a proper seizure, so someone who's having tonic-clonic jerking movements for at least 40 seconds, not someone who just flings an arm out, because that's quite common with pregabalin overdoses. So classic features of a seizure, which is quite easy to recognize. And the RAS score moving from blue into green. Our secondary outcomes, one of the problems with drug overdoses, particularly opioids and benzos, is respiratory depression, which ultimately can lead to respiratory arrest and death. So we're trying to see if by giving flumazenil, we can reverse that effect. And we look at the level of carbon dioxide in the patient's blood to see whether flumazenil is working. We're looking at different types of scores, whether anybody needs intubating and going to intensive care, whether patients die, and look at any other adverse effects during the time they spend in hospital. This next few slides tries to take you through what actually happens when the patient comes to hospital. So first of all, they're identified either by the ambulance service or by the triage service when they arrive at hospital as being an unconscious patient who RAS score is in -5 to -3, who's likely to have had an unintentional overdose. So if someone's found with a suicide note, for example, or a collection of boxes next to them, which look like it was an intentional overdose, they won't come in the study. There's an assessment given at this point. Had they have enough naloxone? Are there any features of opioid toxicity? So if enough naloxone has been given and they're felt to fulfill the criteria, they're then recruited to the study without consent. So no consent's taken. A blood sample is taken from baseline plasma. And then professional legal consent is taken from a doctor who's not involved in the research study in the hospital, who's responsible for the care. That blood sample is sent to a laboratory in London called the ASI laboratory, who identifies all the bloods and actually quantifies the amount of benzodiazepines and gabapentinoids in the blood. So we know whether the patient should or should not have responded to flumazenil. If there's no benzodiazepines, there shouldn't be an expected response. If there's gabapentins and no benzos, exactly what we'd expect. Thus far, in the first 40 patients, the first 36 we've analyzed, they've all had benzodiazepines in their blood, as we presume to be the case. This approach of taking consent is legal in the UK under the clinical trials regulations, and also encouraged by the Scottish Drugs Forum and by the people we speak to who have lived and living experience of benzodiazepine use at the moment when we tell them about the study. Of the probably the 45 patients who have now recruited to the study, none of them have refused to be in the study when we speak to them about it. They've all been happy to be in the study. So what actually happens during the study? So after they're recruited, the patient gets flumazenil or placebo injected intramuscularly. We take a blood gas just before, and that allows us to look at carbon dioxide in the blood and see how that changes over time at baseline, 15 minutes and 30 minutes. Remember that 15 minutes is when our primary outcome is for the RAS score. These observations are basically the RAS scores at different time points. And then everything finishes at 1 hour. We're looking for a seizure up to 1 hour, and we're looking for reduced, so increase in consciousness at 15 minutes. When the study is finished and they've woken up, we then seek consent from the individual patient to say, are you happy that we've done this study? We explain what it's about, and then we ask them about questions about their drug use and about withdrawal, how they feel having getting flumazenil. Do they feel very agitated or not? And then until they leave hospital, we have a daily review. The majority of patients leave hospital after a few hours. We're not seeing a great deal of re-sedation, at least not severe sedation, after the flumazenil wears off. Like naloxone, flumazenil has a short duration of action. And also we're not finding, as I mentioned before, we're not finding patients suffering severe withdrawal having been given flumazenil intramuscularly for their overdose. So the progress of the study so far, we've completed stage 1. We've now identified 2 doses, so 400 micrograms and 800 micrograms of flumazenil versus placebo. We've recruited 12 of 189 patients in stage 2, so that's 48, including the 36 in stage 1. We have 4 hospital sites recruiting, and that's the Victoria Hospital Kirkcaldy, which is a small emergency department, but sees lots of patients and is a phenomenally good recruiter of the study. There's the Royal Infirmary in Edinburgh, the Queen Elizabeth in Glasgow, and just recently the Royal Berkshire in Reading have all started. We have 3 more hospitals starting soon, 1 in London, 2 in the northeast of England, another 8 in process, often in the northeast, but also more widely across the country. As mentioned before, after discussion with the Scottish Drugs Forum and our colleagues both in and out of prison, there's an attempt to get approval for recruitment of prisoners to the study. We have approval from ethics, from the drug regulators, and from the English Prison Service, but not from the Scottish Prison Service yet. We're still waiting for that approval, which we hope will come in the next few days or weeks, but we've been waiting for it for quite a long time so far. So if successful, we'll have another antidote akin to naloxone that we can use in hospital, both as a bolus and an infusion. We can then start to try and use it in the community with an ambulance-based cluster RCT, where ambulances will be randomized to have flumazenil or not, and we'll give it to patients they give naloxone to. Then we'll do a step wedge take-home flumazenil randomized control trial, where we start giving it out to the community in different NHS boards and start seeing the effect. Ultimately, what we want to have is a combination naloxone flumazenil combination autoinjector like this, which is available at an affordable price and can be used by lay people, by bystanders, by relatives, and by family. I think I'll miss out these 2 slides. I guess I always finish the slide with these 2 really great reports, one from the National Crime Agency and one a report by Philip Berry in The Conversation, which is fundamentally saying now is not the time to use drugs. With metomidine and nitazines and orphines coming out and fentanyls around, it's really very unclear what's in anybody's drug, whether it's supposed to be a sedative or a stimulant. There's lots of stuff in these drugs. It's a really dangerous time to take drugs, it seems. So concluding, Scotland continues to be ground zero in the drug death epidemic of Europe. We have not fundamentally changed the picture and got us back to where everybody else is. We're still at very high rates. Unfortunately, epidemiology is changing all the time. And the major recent increase in death appears to be due to low potency opioids, such as methadone and heroin, in combination with high potency benzodiazepine overdoses. It doesn't seem to be due to fentanyls, it seems. We urgently need to understand whether take-home flumazenil can save lives, and to do that, we need to know it's safe and efficacious, and that's what we're doing at the moment in the RUFUS study. We know that nitazines, fentanyls, and orphines are on the coming horizon, perhaps. They haven't come here so far in very large amounts. I'm not sure I know why. I'm not sure what's going to happen, but what we do seem to know is naloxone appears to work for nitazines. There was a study from New South Wales with 28 patients with confirmed nitazine exposure, and they all responded to 400 to 800 micrograms of naloxone. So we don't need to give very big doses, at least not initially. Of those 28 patients, 45% needed a second dose, but they were not requiring the 2 to 4 to 10 milligrams sometimes being used in the USA now for suspected fentanyl overdoses. Thank you very much. Sorry, that was a bit quicker than I thought it was going to be.
Thanks, Michael. Yeah, I was going to say, whisked through it. There's a lot in there, though. Thank you so much. I will offer anyone who's got questions to unmute themselves, or, oh, we got one already in the chat. Kira is asking, have any of the blood samples taken so far detected either novel benzos known to have significantly long half-lives? For example, I can't even actually pronounce that. I can't. Do you
I'll look in the
pronounce
chat.
that?
Desalkyldiazepam.
Oh, gosh. Okay, thank you. Thanks, Kira.
I'm not sure. I haven't looked at those questions. We have data from the first 36 patients, so I can go and look at that. But I don't know at the moment.
Great, thanks, Michael. It'd be really interesting to see if medetomidine was being detected at all, particularly in areas in the east of Scotland.
I haven't noticed that yet. But we've only had 10 patients in Concordia, so we can't publish the data what we're seeing. But I can happily go away and look and come back and tell you. If you send me an email, will be the best thing. I'll put my email
Yeah, no
address in
problem.
there.
Thank you.
If you give me the
Thanks.
question you want answered, I can go away and look.
Perfect.
Brilliant. Andy.
Hi, Michael. Just to say thanks for the presentation. I thought it was fantastic, and I had lots of questions, but every time you flicked to another slide, you seemed to answer the questions as I was going along. The one I was interested in is, if I understood it right, you're saying that the flumazenil is not administered until you know that there's been an adequate dose of naloxone already been administered. And I just wondered, how is that assessed, given there's so much take-home naloxone in the community? So is that dependent on the paramedic having administered the naloxone, or does it also include community-administered naloxone by peers or by family members?
So the adequacy is detected at the moment of recruitment. So does this patient who I'm going to give flumazenil to in the next 5 or 10 minutes, do they need naloxone now? They may have had it in the community, they've sometimes had it in the police cells, they've had it by the paramedics, they've even had it in the ED department sometimes. It's just a question, when I look at this patient in front of me, do they need naloxone? Because I don't want to give flumazenil unless I know there's something which isn't responsive to naloxone there. But if they've got large normal-sized pupils and the respiratory rate is 25, and there's a general clinical decision that this patient now doesn't need it, then they go ahead. We find the great majority of patients do have opioids on board, and about 60% have had naloxone, but about 40% have not had naloxone in the study so far. It's still only 36 analyses of 48 patients we've seen. By the time we get to 200 or 300 patients, we might have a much more refined answer for you. But it's a clinical judgment at the time they're recruited. And we record how much naloxone they've had, whether they got it pre-hospital or in hospital. It's all being recorded.
Brilliant, thanks.
Okay, moving on to Leon, please.
Yeah, thanks. That was interesting. Because of the variance of all your benzos, like Kira's talked about, with going outside the benzos and metatotamine and one of the other benzos, but you have that rapid turnover of the benzos with different half-lives and everything like that. Is it not going to be quite hard to kind of measure within that? You might have the partial reversal, but you're not really sure about some of the benzos bring on fitting faster when they're, when people are cutting down on them and things like that. So there's all this range of different outcomes related to the benzos, and we just seem to have a new benzo every day. It's not that, but it is, the police will jump on one and then another one seems to just be waiting on someone's database, and they pull together materials and boom, and yeah.
Absolutely. I mean, all I can say is that we have a blood sample from every patient, so we know what they've taken at the time we give the flumazenil. We're looking for a response within 15 minutes. So does flumazenil work to stop people dying in the next little time? Whether they then need it again, we can analyze that in time. Once we get more data, we'll see how many patients get required and more doses of flumazenil. I think my general impression at the moment is that people are not requiring more doses of flumazenil. The single dose is generally working. We've had no seizures so far post-flumazenil. So we've had about between 5 and 10 patients have had seizures before they get to the study, and they haven't come in the study. And so we won't know what drugs they've taken. But of the patient coming in the study, they're not getting seizures so far. But we will know exactly which benzo. It's being ASI does an open, time of flight analysis, so they should pick up novel benzos, and so we shouldn't be missing stuff. And we over time will then look at different things. As I say, Kirkcaldy is often clonazepam. In Edinburgh, it's been mostly diazepam, with the odd other stuff appearing there so far.
They do more prescribing in Edinburgh, obviously, so it's so
May all be illicit. I'm not sure. It's very hard to prove whether it's illicit or not. Anyway.
Yeah. It's, okay, thank you. But it's just I suppose when you're dropping in things like methamphetamine and things like that, where you don't know the level of effect that's causing, so it's then hard to. You've just got that small variance, I suppose. So
we will have proof of whether methamphetamine is there, and we hopefully can go back retrospectively and measure the quantity at some point. I haven't seen it come up so far.
Okay, so you're storing samples and we'll be able to do something. But okay, cool. Cheers.
Thanks so much. I'm just going to intersperse with a question from the chat. So it was about the half-life of flumazenil. I think maybe Leon, you already replied to that in the chat, but we're asking what the half-life of flumazenil is, and also do you have a projected idea of timescale on beginning ambulance-based trials?
So it's the half-life is about an hour. It's very similar to naloxone. You start seeing it wearing off after about an hour or so. With the time frame, I mean, we've got another 2 years for this study, 2.5 years. I'd love to have it enough money and enough hospitals to finish it in 3 months and quickly get moving on to the next stage. But we're hopefully getting 15 hospitals, which will allow us to finish on time. It's quite a complex study. It generally requires you need a full-time researcher with the patient, and then 2 clinicians, nurses, or doctors who work with that person. So 3 people for some of the time, 1 person for the whole time. So it's really only a daytime study. And the epidemiology is sometimes you get 3 patients in a day, and other times you'll get nothing for 2 or 3 weeks. It just is so variable what's going on. If I answer the ones in the chat, are clinicians blind to what they're giving? Yes, so everyone's double blind. So we don't know what each person's got. And flumazenil, I think, we'll find out. I think flumazenil seems to work for everything. Works very well for zopiclone, I've noticed. So people are responding to benzos. Even the 200 was pretty effective in most patients. We chose 400 and 800 because the DMC wants to be more reassured that those bigger doses are going to work. But I can't recall anyone, but I'm not really supposed to be going through this analysis, so I'm not looking carefully to answer the question, are people not responding who I'd expect to respond? That's an analysis we'll have later on when the study's finished.
Thanks, Michael. John, do you want to ask your question?
Thanks. Yeah, Michael, really, really interesting. It's great to see this development, and obviously can't come soon enough. If it's all right, I might have 2 questions if there were time. The first one is there anything that will respond to the gabapentinoids, pre-gabs, etc., in the same way that will reverse overdose? Is there anything available?
Not that I'm aware of. No.
Okay.
But there is atipemazole for methamphetamine and xylazine. So we have a potential, but it's a veterinary one. Unfortunately, there's no human licensed preparation of atipemazole, but there is one for that, but not one for gabapentinoids that I'm aware of. I think I would know.
Okay.
I hope.
Sure. Okay. I mean, what one to work on, I guess. My second question is really about, again, expanded utility really of flumazenil, and actually it's got some evidence base in terms of being able to provide a detox agent, but at the moment it's not licensed. And in terms of people opting for detox from benzodiazepines can cause significant challenge. Is there any scope to look at expanding, flumazenil's usage across things like detox?
So I'm not an addiction specialist, so I don't really deal with those environments. I'm very much the acute overdose with the paramedics, and then also in terms of hospital presentation. I'm probably not the best person to answer that question. If we can show it's safe and doesn't cause acute withdrawal, I think at least we'll have the parameters available for people to make those clinical decisions. I'm not really thinking along those lines. I don't have the experience.
I mean, I don't think naloxone has any utility in a detox space. It's a bit brutal, but it does seem that I've known of flumazenil for quite some time and in that space, but it's unlicensed. But it does feel like it could be an opportunity.
Okay.
James, do you want to ask your question?
Yeah, thank you very much. That was a really interesting presentation, Michael. It was really just a comment on the point you made around prisons.
Yep.
It's really more for the information, just to let you know that Public Health Scotland had, under the banner of drug and alcohol MAT standards, we had a presentation quite recently from Chris McGovern, who's he's an intensive care consultant
I heard him talk
Glasgow
on
Island from the
Friday.
And I'm just mindful that there might be some crossover with the work you're doing, because Chris has been meeting with my colleague Sharon Kennedy and others to look at taking forward a piece of work around increased numbers of people getting admitted to intensive care.
Yeah, I saw that.
From some of the prisons. So I just wonder if there's some overlap here in terms of trying to open that SPS door that you're grappling with going forward.
So there was a new person took over called Samantha Recchi about 2 years ago. There's someone before, and she was quite new in post, maybe a year ago. We went to her in October last year, and it kind of got lost. It's been going to multiple meetings in SBS. I spoke to the chief inspector of the prisons on Friday as well, because she was also presenting in the same session, and she said she would talk to people. I spoke to Mary Todd. I've spoken to the Scottish Government colleagues. And apparently what SBS have done is they've kind of got lost, and they've handed it over to Scottish Government legal department. They wanted a legal opinion. They came back with questions. We've answered those questions. We've given them the English HMPPS opinion that prisoners can come in the study. But again, they keep promising every week they'll give us something, and nothing ever comes. It's tricky trying to open that door. But I think people have concerns. It's very valid to have concerns, but the lived and living experience is very strongly viewed that this kind of study is something they really want to be part of. And actually, when people come round and we say, you've been in a study, you were unconscious, we couldn't get your consent, but this is what we've done, this is why we've done it, and they don't seem to stress. And people are saying we are getting consent from everybody, except the 2 or 3 who run off to their appointment when they suddenly wake up and realize what time it is. So it doesn't, the people with lived and living experience do seem to like the study, which I think is reassuring. And we've talked to people in HMP Edinburgh, and they have said they would like to be part of the study. But unfortunately, SBS are having difficulty making a decision. Hopefully, legal will advise. I'm trying every way I can to give them everything they need to make their decision. It's up. They need to make the decision that they're comfortable with.
I'm going to take a question from the chat. So Margaret was asking about, and I don't know if you already mentioned them by name, but you mentioned other hospitals coming on board in England. Can you let us know which ones they are?
In England, yes, if you give me 2 seconds, I'll bring up a list. Okay, it's easier just to show you. I'll just hand over I'll just take over.
I was going to say Laura was raising her hands. You might be able to answer the question, please.
Oh, hi, Laura.
Hi,
So
Michael.
is that visible?
Sorry, I was going to answer that for you, but it's okay. You've got the table now, so that's fine.
So you can see the top 3 have all been done. So Laura is the trial manager who's just spoken, who does everything for the study and is fantastic. She has her and Amy have created this sheet here. So James Cook, Middlesbrough, North Tees. So 2 in the Northeast, where it really is a problem. And I think it was the North Tees who said they're next to a prison and they get a lot of patients coming through. That's the first tranche. And the next tranche is Aberdeen, Sunderland, Bristol, and Ninewells. And then Glasgow Royal Infirmary, Midland Metropolitan, and the Royal Victoria. So there's a group of hospitals kind of there in reserve, but hopefully we'll get up to 15 reasonably soon and try to get the answer we all think we need quite quickly. Did that answer your question? We're not actually looking for more hospitals at the moment. We think these ones should give us enough to try and finish the study in 2 years. So I wouldn't say absolutely not for new hospitals.
Okay. Thanks. And then Will asked, and I don't know if you have already addressed it, but should we expect Flumazenil to be effective, I think, for all benzodiazepines, including future novel ones?
I think so. It antagonizes the site where the benzodiazepines work at. It seems to work. I was surprised it works so well for Zopiclone. And the literature says it does do. So I went back and looked at the literature afterwards. I think it should do. And I think interestingly with naloxone, which really seems to work very well for very potent opioids. So it's their ability to interact, the potency for the interaction with the receptor seems strong enough to have an effect. So I think flumazenil should be similar, but that's rather crude.
And then Rory asked, for the treatment of patients, how did the identification of patients who have had potentially taken overdose happen? Is it just from the bloods, or is it from the pre-hospital identification? If pre-hospital will there be some training for ambulance crews on the study intake?
So the identification is purely on a clinical suspicion. Has this patient, have they responded? No, do they look like they're opioid toxic? If they did they respond to naloxone? It's just about coming in and saying, this patient is unconscious. We know that benzos are really common in this area, which is true for most of these hospitals. We have given enough opioid on board. So we're not, the actual triage is done by normally a consultant emergency medicine physician in the hospital saying, I think, from everything I can think of, this is probably a benzo overdose, and they'll come in. They may well be a gabapentin overdose. We can't exclude that. We can only exclude the afters when we look at the bloods. So prospectively, when they come in the study, it's purely based on suspicion, and we may get it wrong sometimes. But thus far, practically everybody's had a benzodiazepine on board. We've not got it wrong very often. So naloxone, flumazenil, and atipemezole, huh? So what I would like is a suite of auto-injectors. So we're doing a grant at the moment, trying to develop an auto-injector where the auto-injector, as you use the auto-injector, it gives off a signal telling you this auto-injector is being used. Currently, we know there's lots of syringes out there, a lot of intranasal devices out there. We don't know who's using them, where they're being used, why they're being used. If we can create one which is tagged and sends off a signal every time it's used, that starts giving us some idea about where it's being used, when it's being used, and we actually know which precise auto-injector is being moved. So perhaps the vision for the future is to have a range of different auto-injectors with a needle held within the device. You simply push it against your leg, flick the top off, and the drug is injected. They're all standard doses. At least I can envisage that at the moment. It may be a way of making it with variable doses. And then you would have a pink one would be your naloxone, you would have a blue one would be your flumazenil and naloxone, and you might have atipemezole in a pink one. And so you'd have 3 or 4 different ones, and then the public health services would make a decision that, we're now seeing in southern Edinburgh a flurry of deaths, a flurry of auto-injectors being used. We know there's something going on here. Perhaps what we found out, there's a high dose of methylstomidine involved, and therefore we should be having an atipemezole naloxone combination. Those are the kind of things we'd be thinking about as being a potential vision.
Brilliant. We still have plenty of time for more questions, so really encourage people to ask all of the questions that they have. If you want, I will ask one myself while people are thinking. But you mentioned something about the difference in withdrawal from flumazenil and naloxone, and I was just wondering, is there anything else that's been sort of surprising about this study and what's happened so far compared to when you were designing it?
So no, I think that's the key risk. I mean, there have been some very concerned emergency physicians that have a bunch of naked men running around the department in terrible withdrawal, the RAS +4s as a result of this study. And I've seen it expressed. People have said, I am not recruiting patients to this study because it's going to cause chaos. We're not seeing that. I don't know why exactly, because there is a fairly reasonable concern that patients who are benzodiazepine dependent getting flumazenil might suddenly become really severely overagitated. That's simply not happening so far. We've only had 48 patients. A few of them got placebo, so we're only talking probably 35 to 40 patients who actually got flumazenil, but they're not withdrawing in a very sudden way, which is definitely something that does happen with naloxone. Nowadays with naloxone, if someone's coming to hospital who commonly uses drugs, you wouldn't give 400 micrograms of naloxone to the patient. You would give 40 in increments. You drop 400 into 10 ml syringe, give small amounts, and try to stay in control of preventing the withdrawal. We're not doing that with flumazenil, and we're just giving a simple 800 or 400 microgram dose intramuscularly, and they're not withdrawing. That's really all I can say at the moment. That's the only surprise. I guess the other 200 and 400 both seem to have worked quite well. These quite low doses I remember giving 2 patients flumazenil 200. One didn't respond at all. So you don't know whether that was gabapentin or whether that was because the dose was too small or whether it was placebo. But the other patient I gave it to, her partner, He responded beautifully, and within 5 minutes was beginning to wake up. At 15 minutes, had a RAS score of 0, and then went down to -1 after an hour. So it seems to be quite a gentle drug, which is rather crass, rather a crude comment. But it's going to be interesting as we get more and more patients to use it. We may end up have a drug which people are quite confident to use.
Yeah.
So I guess I'm just thinking about, you've been having conversations with lived experience groups from SDF, etc. And I just wonder if it has ever come up, or if it comes up in the future, maybe there's an opportunity to discuss this, because I really like the idea of the vision for having these kind of auto injectors. But we're also aware that sometimes people are not phoning 999 because of a variety of reasons. Sometimes it's due to concerns about stigma they might experience in the ED, but sometimes it's due to concerns about potential police involvement, and so that prevents them from phoning 999. And we know that at the moment there will sometimes be an naloxone administration in the community where there's no involvement of ambulance service at all. It's not, 999's never called. And so I guess thinking about, if we're going to offer these new devices, how could we future-proof that? And is there a merit in having a conversation with lived experience groups, maybe to start with, around what could a change, particularly I'm just thinking in Scotland, look like, of some kind of Good Samaritans legislation, etc., for overdose responses and people having some kind of immunity for the kind of legal consequences that come with illicit drugs? And I just wonder if that's a topic that's come up for you at all in those conversations.
So in the grant application, we have lived experience. Jason Wallace is a co-applicant on most of the stuff I do. We do talk with Scottish Drug Forum about many of these issues, and we do integrate lived experience working groups and discussions. So Lisa and I see a benzodiazepine using group in Edinburgh every 3 to 6 months and talk to them about the study and try and get their feedback. So we try and work both with the individuals using benzodiazepines and people like SDF who have a more of an overview of what's going on to try and get those views. They did say that they thought 90% of naloxone was given without calling the ambulances, but it's very hard to really know an estimate. They also believe that naloxone syringes are left in various places around the world, around cities, Scottish cities, so they're available where people do inject. Clearly, it's a very, very important perspective. The one thing about this device is it will not be telling you where you are when you're carrying it around with you. It's only when it gets used, it'll tell a signal where it's been used and when it was used and what the drug that was injected. So the idea is not tracking the individuals. And again, we're having those conversations with people with lived experience to see whether they believe that's something they'd be willing to live with. Maybe some will, some won't. But hopefully we'll get more information for public health and for the ambulance services, because in future, it may be possible to have an ambulance sent out when it's been used. As you say, maybe that's not what the users would like, but they're clearly safety issues. So those discussions are going to have to be really quite long, drawn out, and really interesting.
Another question from Leon. Is there potentially a rapid blood test, for example, finger prick, that can check for what is present in blood so as to be able to identify with multi-inject?
Not really rapid. You can do ELISA-based ones, but they're kind of crude, and there's so many different drugs and so many things going on all the time. It's very difficult to pick that up. What I was trying to do was pupil movement. So Rebecca, who's on the call, put me in contact with an American colleague of hers who was looking at pupil responses to light, which are affected by the drugs in the system. So we were trying to put that into the study. So take a pupil, put 6 seconds of light into the eye and see how the pupil responds. They use it in the States for checking if people are taking their methadone, for example, because if you're on methadone, your pupil behaves in a different way to how it does if you're not on methadone. So it's just every morning you take your mobile phone, take a photograph, and you kind of prove you're taking various drugs. We wanted to look at that approach. See, can you pick up this multiplex of 15 different drugs in there? How are you going to is there a benzodiazepine behavior in the pupil, which will tell you this patient's taking benzos? I'm also working with colleagues who look at breath. So there's a way of taking breath sampling and look at the breath and how your body responds to these various drugs, and the drugs themselves and their variable volatility may give you a signal which allows you to determine what the person's taken. Unfortunately, that at the moment doesn't have an inbuilt analyzer, so you have to take the breath sample and send it off to a lab who will then analyze it. So it's useful 3 or 4 days down the line, and we may be able to get a signal which is easier and cheaper perhaps than doing blood samples. But there's no real way at the moment, I think, of getting a comprehensive. There's one device which is used quite widely. We can pick up maybe 25 or 30 drugs, but they're not quantitative. So you get a signal for something, but you don't know if that's the one that's causing the unconsciousness. So it's very difficult, shall I say.
Yeah, Leon, go ahead.
I suppose you're not sure which one's causing consciousness, but you don't know what will cause consciousness out of that as well. So, you know, it's useful knowing if you're looking at a multi-ject kind of thing, then you would just go for what was present because you don't know, you will never really know which one's causing it because just the various combinations and whether, you know, one potentiates the other depending on gabapentin and heroin, etc., like that. So it'd be just useful to know what was present if you're going to have this range of things, what you can use rather than, you know, though if they don't cause issues, then, you know, just having one that just does it all is probably a, you know, like a general purpose, you know, wide spectrum antibiotic, just that approach kind of thing. So
I think it has to be used very closely with public health surveillance of what's going on, just having some understanding of what's going on in the community, what seems to be causing the deaths, what seems to be causing patients coming to hospital, will allow you to make somewhat intelligent decisions about which auto-injectors you use. If they're safe, then great. The colleagues I work with in terms of communications, they have this kind of science fiction vision that they can somehow, when the needle goes into the person to inject the drug, you can then analyze the blood on the needle and find out what drugs are there. They seem quite confident about this. I think that's bordering on bonkers to imagine you can get.
It's a metal thing, so there would be some kind of electrical reaction there that potentially, just thinking very quickly on that. But yeah, I suppose it's that when you're looking at public health, though, you know, the rapidity of the changes in the drugs and what's out there at the moment is, you know, and I've been in this area for quite a while, so, you know, this rapidity is not a usual thing. You know, it's not traditionally what happened, but it's partly to do with law enforcement and I don't know, some smart person has got a list of all the benzos and all the things that have gone, like nitazines, you know, in the 50s and things like that. They've pulled the science and have studied these things to pull together. But that, you know, we don't know we may have an idea of what was there last week, but if a bunch of people suddenly are dropping, you know, we're not likely to know what's actually affecting them at that time. So it's having a broad spectrum thing may be and not worrying about what's on board and just going boom.
We just kind of get a low enough dose in there, which is effective enough to make people move from blue into green. Stay at -2. If you're at -2, that's fine. You don't have to be 0 or +1, but just enough to get them safely out of the way. They're not going to have a respiratory arrest until someone finds them. It's a good idea. And looking at Rebecca's question, so we're using a military grade auto-injector. It's very cheap, 15 euros a piece for an atropine auto-injector, and adapting it for this in our studies. So they are intended for use by the persons. They carry 3 each, and when the cloud goes up and they're told, inject yourself because there's a nerve agent attack happening, they simply inject through their trousers. They don't pull the trousers down, they just go straight through the trouser of material into their leg and they'll inject themselves 3 times. Clearly, it's a very different situation in a patient who's taken an unintentional benzodiazepine or opioid overdose. But the same principle, they're not going to do it themselves, but their friend can take it, or you can inject your friends. So either the friend takes it off them and injects them, or you have your own and inject them. But the same idea. And alcohol overdose deaths.
Yeah, do you want to quickly respond to that, if you can? Is there any similar word for alcohol overdose?
No, I mean, there's no actual alcohol withdrawal antidote. You simply let people keep them safe. So the way we treat patients with alcohol overdose is you try and keep them safe within a paramedic or a hospital and support their breathing if they need it until it wears off by itself. There's no actual antidote I'm aware of for alcohol, though it's the same receptors as the benzodiazepines and gabapentin. Just think about that. And we could use Rebecca's idea about using sodium bicarbonate using diazepam intranasal ones for cocaine agitation. In the clubs, if someone's extremely agitated, you could just simply give them a little intranasal 10 milligrams of diazepam. May take the edge off someone to then allow them to be talked down from the situation they're in. So there's lots of antidotes we could use. Okay, not seen it have wake people up so much, but I guess we'll find out if patients have got alcohol on board in the study and see how they respond.
Brilliant. I'm going to call it a day there. Thanks everyone for contributing your questions, and also a really nice comment from Andrew there about the study in the chat. I'm going to just put the link to the study website again for anyone who wants to kind of follow along with what's going on, and their contact details there for Michael and Laura and other people on the project. So thanks everyone for joining today, and thank you so much, Michael, for taking the time to present the study, and have a lovely rest of your Tuesday.
Thanks, Lisa. Thanks, everybody.